Hi, everyone, and welcome to another episode of Enjoy the Life You're Living. I'm your host, Jana Rieger, and today my guest is Dr. Tim Stockdale. Dr. Stockdale has served as a speech language pathologist primarily in university and acute care settings. He's taught at the graduate level for several years and is the five-time director of the Hard to Swallow, a Catalyst for Change in Dysphagia Management conference that's held at Rocky Mountain University of Health Professions. He also recently founded Gap Education, which is a continuing education company that's aimed at addressing gaps in dysphagia education and intervention. Also, through this company, he hosts the popular Swallow the Gap podcast. So I'm really excited to have him here today. Let's go. Hi, everyone, and welcome to another episode of Enjoy the Life You're Living. I'm Jana Rieger, and today with me is Tim Stockdale. I'm really looking forward to this conversation with Tim. Welcome.
Yeah, thanks for having me. It's good to be here.
Yeah, for sure. So, Tim, I would love to start by hearing some of your personal story, your background, how your journey as an SLP happened, and then how you came to some of these new things that you're doing in your career.
Okay, yeah, no, I'll happy to do that. Just if I get too into the weeds with it, it's something I'm really passionate about, let me know.
Yeah,
Redirect me. But I think it comes
100%.
from I think it comes from a place that probably a lot of your listeners can relate to as they go back and they think of through their careers and they think through their education as no matter what school you went to, I don't feel like the education for speech pathology can be comprehensive enough for some of the specific focal areas we have. We have 9 diagnostic categories, and we have 5 or 6 semesters of grad school, and undergrad's variable. And so, you get out there, and your clinical fellowship also might be variable. You might have somebody who's a really strong mentor, um, or you might have, somebody who's calling in and, just not giving you the support that you need.
Yeah.
So anyway, as I was practicing in different places, seeing a lot of variability, but also looking at some of my own knowledge gaps, maybe coming out a little bit overconfident, like I know this really good, really well, but then like seeing the variability and wondering why and having things presented that I don't know. I'm like, oh dear me, like why didn't I understand that? And
Mm,
so around this time, or a few years later, I guess, there was some research that came out that really challenged SLPs for what they know for dysphagia in particular, for some of the medical facets of speech
mm,
pathology. Just with our knowledge of typical and atypical swallowing, our
mm,
ability to match specific treatments for dysphagia
mm.
with specific impairment or specific pathophysiology in the mouth and throat. And so between all of these things, I'm like, these are pretty big repercussions that we could have if we're doing something wrong. Like if we're not
Yeah.
considering the whole body, we're very hyper focused maybe on what's going on in the pharynx and what could be going on in the trachea and lungs, but doing things that may be a detriment to the patient in another way, like
Mm,
overuse of thickened liquids or overuse of any number of things that may subsequently cause issues with the urinary tract or cognitively, as you see, like older folks who have
mm,
not the same ability to maintain homeostasis within, balancing the internal and the external. They have this reduction in homeostasis. So homeostenosis, as it goes down, they have reduced ability to be able to maintain homeostasis. And so if you have an 80-year-old man or woman or who has a urinary tract infection, it's going to affect them a lot differently than it would affect us. And so just basically the idea that sometimes because we don't know enough in this very important category of swallowing disorders and other areas too, we might do more harm than good. And it's not necessarily because of something that, we're trying to do, right? No one's trying to go out there and to harm somebody. And I'm not trying to point the finger at anyone else or myself or whatever to say like, you should be doing this, you should be doing better. But to look at what the situation is, to take a look as objectively and as fairly as possible,
mm,
to say there are things that we're doing that are very high impact that need to be better.
mm.
And so that's really what led me into my passion for education, graduate education, and continuing education, particularly for dysphagia, but many other things. But dysphagia, I'm very hyper focused on. I'll say that.
Yeah. What do you think it was? What is it about dysphagia that drew you in to that as like an area that you're really interested in and one that you want to help other clinicians know more about and treat patients better, let's say?
All right. If I start saying this in the way that it really happened, it's going to sound like a cheesy fairy tale. But like I was
Cheesy fairy tales are good. Let's go for it.
okay, all right. So I mean, I was didn't know what I wanted to do. I had a very general kind of bachelor's degree in different concentrations in different areas. And I was thinking about speech pathology, and I'd shadowed in some place, and I was like, yeah, this is interesting. This is fine. It wasn't something that was really striking a chord with me until I went and I shadowed in a hospital, and I watched them doing modified barium swallow studies. And I was just like, this is fascinating. Like, I would think that there would be MDs and DOs doing this, but speech pathologists can do this. I thought it was so neat. And so that got me hooked. I thought the medical, the physiology side of it was just extremely fascinating. And I had my sights on it. And that's something that, even learning about other areas of speech pathology, I've gotten a lot of other interests within that, but that's never left me. That fascination for the aerodigestive tract. I mean, knowing this plethora of muscles and muscle groups and cranial nerves and spinal nerves that go into the coordination of efficient and safe swallowing and airway protection with breath swallow coordination and all these different things. It's just extremely fascinating to me. And it's an emerging area, really is still, in my opinion, an emerging area of science,
Mhm.
at least rehabilitative wise. I mean, there's so much to it that I feel like I still a pioneer in this one area where there is so much more to learn. So that's largely what I would say where that's come from.
Yeah, and you truly are pioneering work in it because now you've taken that love for dysphagia and you've
Mhm.
started something, gap education. So, can you talk a little bit about your journey into gap education and for our listeners, just what is that?
Okay, yeah, absolutely. So let me start off with what it is. Gap Education is an education company predicated on gaps, right? If you
Mhm.
think from a business or a process perspective or many other paradigms, the idea of a gap is something that's missing. When you consider where you are right now versus where you want to be, there are gaps between you and where you're going. Are there things that keeping you from being efficient or what you want to be? And so the idea with this is there are gaps in our education, there are gaps in our practice, there are gaps in our research. And so I'm hoping with this company to target those gaps. In fact, the podcast is called Swallow the Gap, like swallow, consume, get rid of it. Not that that will ever happen, but trying to make push a push in the right direction to consume the gaps that we have by getting people talking, equalizing the power distance really with so many of the researchers and individuals who write our textbooks who we may perceive as being untouchable. But I've been so fortunate to find that so many of them, the large majority of them, are just kind, enthusiastic, giving individuals. And so these conversations make them real, right? When they come onto there, you get to hear them just as another person, like your next door neighbor
Yeah.
in this context. And you're like, all right, there's not this big power distance so much. I could send them an email or follow up and feel totally comfortable doing that. And it gets clinicians and whoever's driving to the hospital on their way to work or wherever, thinking about things that are relevant and important. And so wherever they are, that they can begin this process of addressing these gaps where they are, in their facility or where they are in their growth and their learning within their sphere of influence. It gets everybody involved. It's this idea of synergy as being a catalyst because if we were dependent on what I could do, like we'd be totally messed over because there's just like so little that any one person could do. Um, but when you get other people involved and get synergy, it's like the idea of, one spark versus a bunch of sparks together to turn into this blaze of glory. Wow, that was one of the corniest things I've said in a long time. This blaze of glory, this for swallowing disorders. And so that's the idea. So some of the things that helped to lead up to it, I talked about the background a little bit, but in one of the most recent places I worked, Rocky Mountain University of Health Professions, they were extremely supportive in starting a dysphagia conference predicated on a lot of these gaps. It'll be in September this year. It's hard to swallow, catalyst for change in dysphagia management. And so I've been hosting that for a while with their support, and just met some of the most brilliant individuals in our field who are also extremely kind. And so that is what really got me started within continuing education, I'll say.
Yeah, fantastic. And so if we talk a little bit more about dysphagia and um, dig into that a bit about things that perhaps you've seen in some of the conferences that you've put on. So some of the, let's call them hotter topics in the area
Okay.
of dysphagia. And I would say one of those is, although it isn't necessarily the most medically based topic, but
Mhm.
it is, which is quality of life.
Oh,
So
yeah.
I'd love to talk about what you've experienced in terms of when we think about patients, when we're making dysphagia recommendations for dysphagia,
Mhm.
when it comes down to quality of life, what are some of your reflections on that from your experiences, either clinically or in these conferences that you've put on?
It's a great question. And it really goes back and gives like a broader, bigger picture perspective for why we're doing what we're doing, in my opinion. And so within the last several years, I've shifted into this thought paradigm. Well, maybe it's been a gradual shift, but I guess I'm trying to better define it. The idea of there are these anchors, pillars, whatever you want to call them, that are important within dysphagia management, of knowing the why we care, not just, oh, they aspirated, let's, run away, or let's throw some recommendation at them, but they have reduced swallow efficiency or reduced swallow safety or something like that. So why does it matter? And to me, quality of life is one of those pillars. I look at I look at nutrition, look at hydration, I look at pulmonary sequelae, pneumonia, asphyxiation, things that affect your respiration or your ventilation, and quality of life. And just to throw out there, something that was kind of validating with this is I was teaching this within the dysphagia courses at Rocky Mountain University. But then Alicia Vose came, who is, a role model of sorts for me. I think she's maybe a little young, like a year or two younger than me, but still a role model. She's done a tremendous amount. And so at this conference, she's talking about the same thing. And I'm like, yes, like, yes, exactly. And so like, it was so cool because like I promise you, not to my knowledge, like I didn't copy, but it was kind of in parallel that she had these anchors. And I think she's doing something actually with Ed Bice, a write-up. And so keep your eyes open for that, because this isn't mine. It's just a concept that makes sense. And I think multiple people are discovering it. But so like if your swallowing disorder is not impacting your hydration, your nutrition, your quality of life, or your pulmonary system or your health, whatever, why then should we mind as clinicians? So like we can have functional aspirators, somebody who the coughing isn't nagging them. But if it is, then that could be an impact on their quality of life. It might be embarrassing whenever they go out to eat. Or if the aspiration's not causing them, they're not likely to asphyxiate, or it's not causing a pneumonia or something like that, then my thoughts are like, well, maybe if the patient doesn't care, then we shouldn't care, right? We can
Mhm.
inform them and say, if you become ill, this could get worse and this could affect you in a certain way, or what have you, if it's a progressive illness. And certainly, provide education, but at the same time, this really comes back to being patient focused and supporting autonomy, because it puts the reins back in the patient's hands. We take away this idea that we're the police and we're the diet police, and we're going to say, you got to do this or else. And also it exalts quality of life because through our education, we blend with their values, or let's see, not blend with them as in like we share them, but we support whatever it is that they value, and putting the decision back in their field through our education. And so it becomes more of a symbiotic process versus this very power distance medical model where it's you're the clinician and they're the patient and they've got to listen or they're non-compliant.
Mm.
And that's really kind of a toxic type model, in my opinion. But one other thing with the quality of life, so when we put the decision back in the patient's hands, that exalts quality of life, of course, but also the idea of thinking about not only how can dysphagia affect your health, but how can it affect your quality of life, right? Your ability to go out and eat with family and friends, your just so many other things, your enjoyment with the pleasure of eating and drinking, those types of things that sometimes can be a consideration that we leave out or that we think as being less important than the health, so, sequelae or whatever would affect our health, when maybe that's not those aren't the values of the patient. Maybe
Mhm.
the values of the patient, they care more about their quality of life than tacking on an extra 3 years to their life. So anyway,
Yeah, for
that
sure.
may be your answer in more. I'm sorry.
As you're talking about this, I'm thinking back to early days in my career when,
Mhm.
at that time, really, if you saw any aspiration, it was like, don't eat my
Yep.
mouth, and it was like,
Yeah.
holy cow, the restrictions that were put onto patients were immense. But I also remember
Mhm.
at that time having a certain amount of fear as a clinician that if I don't tell them this, like if something bad
Absolutely.
happens to them, it's back on me. So what are your thoughts about the new clinicians who are coming out? Let's take it back to education. Like, what
Mhm.
are the best ways to provide that balanced education for them between like the medical aspects of what's happening and then the quality of life aspects, and having them feel confident when they go out that they know what to do?
So the question is to provide the new clinicians with education or for them to provide patients with education?
The new clinicians, like how do you think we best make them feel confident in the area of dysphagia that they can provide recommendations that
Yeah.
potentially will allow patients to be part of that decision and have that quality of life, but not let the clinician feel that somehow they've not made full medical recommendations. Because I think
Yeah.
that that tends to be where we fall back to is like, I'm just going to make the medical recommendation here.
Sure.
Keep it safe, keep the patient safe.
Absolutely. Um, there are a lot of really good trains of thought that we can tangent off of that. So one of the things that I think is key when you put the patient's quality of life first through facilitating autonomy and being a collaborator, you also put your own quality of life first because you free yourself from fear.
Mm,
Not completely, but you free yourself from making just decisions based upon fear that I'm going to lose my license or something's going to happen to this patient and I'm going to feel really bad about it because you take the locus of control away from yourself
mm,
and you provide it to the patient where it should be.
mhm,
And so with that, it's like, well, well, how do I do that? Because you still have to provide education. It's not just like, well, this is what I saw, but I don't really care. You can do whatever you want. Because like that's too far to the other side versus like, well, I saw this. These are some options. Here are pros and cons of each option. Here's some data behind the pros and cons of those. And so, but ultimately it comes back to you and what's most important to you. But I'm here to answer your questions. I'm here to provide you with the information to help you make that decision. I mean, me personally, I might even say like, if it was me or my mom, this is what I might do, but also don't want to bias them too much. But at the same time, if they want to know that, like, sure, yeah, I'll tell you, and this is why. But so there's that. And in order to do that, you've got to have that information, right? And we
mm,
don't have it all, at least like a new graduate. There's no way. So one,
mm,
don't hesitate to collaborate. We
mm.
can't, I mean, not all of this is within our scope of practice, like the nuances of nutrition and hydration. We know some of it. We don't know all of it. We can learn more, but we might never be to the stage a dietitian is. So
Right.
collaborate with your dietitian.
Mm,
Collaborate with your pulmonologist. Collaborate with, your social worker for quality of life issues. So many people, like identifying your resources, not just in things you can learn from a book, but people who can support you. Because I mean, they've gone to school for years too. They have resources and they're going to be extremely helpful in this. So also the idea, though, that don't rely solely on your education and your clinical experience. You can't
Mhm.
learn it all, and not everything you've learned is right.
Mhm.
And I don't mean that to be critical. Well, not a critical of any one place, but that's just how it
Mhm.
is. Like we've all learned things that aren't true, whether
Yeah.
it's at an externship, whether it's at our university clinic, or whether it's in our university classroom. It's impossible. It's impossible. I'm sure that I've taught people things that are untrue, and I'm sorry, but I also realize that I'm imperfect and I see that as an area to grow. And so it's not meant as a criticism in from a super negative perspective. It's just saying things as they are. Really think about what you've learned, ask questions, and through, I think, self-reflection, you can really identify what these things are that you don't know, and then look for resources to learn more about them, to learn more about, well, if I'm concerned with aspiration because it could cause someone to asphyxiate and not be able to breathe, or it could cause somebody to get pneumonia, then you've reframed the question to not just how can I keep them from aspirating, but like what can we do to facilitate them not getting a pulmonary infection? Well, oral hygiene is huge. Look in some of John Ashford's stuff. Um, Other medical comorbidities that can impact your immune system. Like that's another one. If you look at Langmore et al. 98 for being dependent on other people for oral hygiene, having a tube feeding, things like that, then it allows you to critically think about the big picture items and not just the aspiration. But there's a lot to learn there. So I would encourage you to be, very reflective in what you know and what you don't know, but also be very motivated to go out there and learn more because as the system is right now, so much of that falls back upon you and me as a clinician to learn these things for ourselves and translate them into whatever our own unique clinical setting is.
Yeah, certainly. And I think that's what's so nice about continuing education because as clinicians, we're busy. We just don't have time to be digging into the literature, understanding what the latest and greatest is. And that's what's so great about having people where come on to these types of, say, the courses or the podcast that you're doing, who can actually inform you of like what's new and what's at the top of our understanding in a particular area. Let me summarize it for you, and here you go, rather than having that feeling that as a clinician, you need to be the one to do that. So it's you still need to be a consumer of the literature, but maybe in
Mhm.
a different way that actually works with um, your daily life as a clinician. Um, so one of the other things, Tim, that I wanted to talk about was your special interest in respiratory conditions. You've mentioned it a couple times. It's interesting. Again, as clinicians, we know that the airway is at risk. We know that there can be pulmonary complications. But I'd love to hear more about your journey into that realm. And just again, if you can pull it back into quality of life for patients as well.
Wow. Just really quickly, I wanted to dovetail on something that you mentioned right before that
Yeah.
about some of the benefits of continuing education. So with that, I agree that having people who are doing research full time, like they are going to consume so much more of the literature than the average clinician has time for. And there are very efficient ways to learn. So I think it's smart to learn efficiently, right? But at the same time, you also mentioned that we're to be a consumer of the literature. And so I agree with that too. There's a balance there of not just listening to, what people say on podcast or in continuing education, but consuming it and critically thinking about what we see as well. So I appreciate that balanced perspective of considering both of those things. Now, the respiratory system question, I can trace it back to a course I went to in California with James Coyle,
Mhm.
Dr. James Coyle,
Mhm.
at the University of Pittsburgh. Just brilliant stuff, brilliant material on breath swallow coordination, how respiratory rate can affect that, how high flow nasal cannula creates positive pressure that can increase aspiration risk, and a number of things like that I'm just like, why didn't I learn this in school? Like we all need to be learning about stuff like this. And I just thought it was really fascinating, and it makes sense because our mouth and our pharynx are a shared track, right? Air can go through there and food can go through there, and then it splits, either to the lungs or either to the esophagus and to the stomach. And so it makes sense. It's an aerodigestive track that we should learn about the synergy and the effect of breathing on swallowing and dysphagia and the pulmonary, how dysphagia then can affect the pulmonary system, and then how that can go back and affect swallowing. Like, it's a very synergistic, symbiotic system that when you affect one, you often affect the other. And so that's one reason why I'm very passionate about it. I think it makes sense. I think it's interesting too, but I think it also makes sense.
Yeah, and it's really interesting what you'd said about when students are being taught about these things. If you think about it, the respiratory system and the voice, for example, those two
Yeah.
logically go hand in hand. And I think we do a good job of teaching our students, like, hey, it all starts with the respiratory system for speech
Oh, sure.
and voice. But I don't know that that same teaching is common around dysphagia. And what I love is that it's getting more and more airplay now, that,
Sure.
you really, like you said, these are structures that are in a symbiotic relationship and they need to be considered together. And I think, there was some early research on the coordination of swallow breathing that started coming out. And I just
Mhm.
love to see that more and more now people are talking about these
Sure.
relationships.
Yeah,
So
absolutely.
yeah, I'm looking forward to hearing more about that. And I know that it's something that you're putting some courses on, so I'm really excited about hearing more about that as well. So,
Yeah, thank you.
um, if you had a magic wand and there was one thing that you could change in the quality of dysphagia
Mm.
education right now in the universities,
One
what would
thing. Oh
that
dear.
be? Just one thing, a magic wand.
Yeah.
I know that's a tall
Um,
order, Tim, but
I need two magic wands at least, because they're two things that really go hand in hand. Um, the duration of time spent on it. I would say that would be the main thing. The other thing, the other magic wand, because I'm cheating, is the ability to blend clinical practice into our didactic coursework more. And the reason why that's secondary to time is because I think that there are teaching methods that you can use case-based learning to really infuse that within your curriculum.
Mm.
And that helps students to see the big picture and understand why they're doing this, not just like, oh, these are the structures in the mouth, and this is the, blah, 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 whatever, that they don't have like a place to anchor it with, why that's important, why that matters, that really
Mm.
makes it stick. So the clinical side, really infusing that together, clinical education with the didactic coursework, I think is an optimal thing. But if you don't have that ability, it would be time. It would be time, because you can still put case-based learning back into there.
Yeah, certainly. And I know that, again, just thinking back on my own experience, and when I first was working at the university, the amount of time that was dedicated to dysphagia education was abysmal. And it was like, guys,
Yeah.
this is the one area where we're sending clinicians out where they could actually, it could be a life or death decision that they're making. So why aren't we spending more time educating our students? And so there were lots of changes over the years. I'm happy to say that were made in terms of time, but I like
Oh
that.
yeah.
I'd still think there could be more time. So if I had a magic wand, that's what I would do as well. Definitely.
Yeah. Oh,
Yeah.
absolutely. I guess it puts it back on us, because until that changes, we have to make our own time for like
Yeah.
the continuing education and whatnot. And I appreciate you alluding to the course that's coming up, that's related to pulmonary issues. So dysphagia management in patients with pulmonary compromise,
Yeah.
largely focused on the intensive care unit, but really going beyond that, getting into a lot of these topics with, Martin Brodsky, Joe Puntiel, Kendra Grand, and George Barnes, on April 20th. And is it okay if I throw out the website too?
100%. For
Okay.
sure. For
I
sure.
figured as much, but I feel like earlier, I didn't take it anyway. So
Take
you can
advantage right now.
there we go. So it's either gapslp.com/live courses, or Swallow the Gap, which is the name of the podcast, swallowthegap.com/live courses. And yeah, that's on there. Early bird rates are up, and really appreciate you encouraging me earlier to put that information out there. If I didn't believe in it, I wouldn't be putting it on. Of course, I'm trying to, change and support myself with that too, but we're also trying to make it extremely affordable right now to get a lot of people in there. And I think it's incredibly important. I try to identify areas of interest and areas that I think are really important. And so this whole idea with breathing and, the pulmonary system and swallowing is one of those, as you mentioned earlier. And so that's largely what this course will be based on.
Yeah, yeah, I think it's fantastic. And you have a great lineup of speakers. So I
Thank
know
you.
I'm looking forward to it. In
Yeah.
case somebody is listening to this after that date has passed, do you think will this be
Ooh.
something that would be available online to register for a recorded version of it, or is that not in the plans right now?
Um, well, it won't be recorded, but there will be other courses. There will be
Right.
other courses. That's the intention, to do something with head and neck cancer, to do something with leaving the idea of fear-based practice within the fluoro suite to more evidence-based practice in the fluoro suite. There's some different ideas, and certainly open to more of them. You're welcome to, shoot me an email, tim@swallowthegap.com, and say, hey, I'd love to hear about this, or I really think that this is a major gap, because this is all in the making. Like, it's a one-person company for right now, with a ton of support from so many people on the outside, including the speakers, especially the speakers who are willing to do this for probably a lot less than they're worth as far
Yeah,
as compensation. So
for sure, for sure. Um, so this is one question that I always ask all my guests who come on, and it gets back to this whole idea of quality of life.
yeah.
And that is, what does the phrase "enjoy the life you're living" mean to you?
Hmm. It could mean a lot of different things, but one of the most impactful ways that that phrase, I think, can translate to my life or to anybody's life is, we're often extremely busy. A lot of things going on, and that can distract us from the beauty around us,
Mm,
whether that is our family. I have a 6-year-old and I have a 9-year-old. To me, that is absolute beauty, not just in seeing them learn and grow,
mm,
but the love that I have for them. I've been working a lot in my basement, and there's a window, and that's great. But still, I walk outside and I'm like, ooh, this sun feels so good. And like, it just does something. And you get so caught up in the work you're doing that you can forget to, and about the life you're living and enjoying the life you're living. So, in not forgetting one of the major reasons why we're doing the things that we do, not just to get rich for the sake of having money or to get a big house or whatever, but really enjoying what we have around us, what's accessible to us. And I think that liberates us from, being a slave to work and being a slave to the things that we have to do.
yeah, isn't that true? And
Yeah.
I'm sure that you're on this entrepreneur journey right now. And how does that fit into enjoying the life you're living, Tim?
Well, there's some more control in that.
Uh,
Um, you can reduce bottlenecks. You can pursue things that you are passionate about. There's
yeah.
a whole lot of other stuff you have to do, like accounting and marketing and like all these other things to support that. Um, but I think it largely comes to, I can focus on things I'm very passionate about.
Mm,
And I mean, within this particular one, I get to meet a lot of really cool people and talk with a lot of really neat people. And I love people. And so like, that excites me. And that brings me a lot of quality of life, I would say. Um, but yeah, definitely a lot that goes into it. But I would say the independence to pursue things I'm passionate about is a
mm.
large part of why this is important to me.
Yeah, certainly. Well, thank you so
Yeah.
much, Tim, for having this conversation today. And we wish you all the best with Gap Education. And I just can't wait to see where it goes. I know you're going to do great things. And thanks again.
Yeah, absolutely. Thank you so much for having me on. Really appreciate it. And this really brought out some nuance to these things that are important to me. So I appreciate the ability of you to ask the right questions to really get there too. So
Yeah.
thanks. Have a great weekend.
Thank you.